Meenu Bajpai and Dr. Kalpana for allowing me to introduce this course and just outline pediatric urodynamics. Pediatric urodynamics brings to mind reflexly cystometry. However, that is not true because urodynamics has a non-invasive, according to ICCS definition, urodynamics has a non-invasive along with the invasive component. Many of our patients would have had the non-invasive investigations by the time we are managing them, and this consists of history physical examination, a simple frequency volume chart recording fluid intake and voided volumes, along with a focused renal tract ultrasound scan. If facilities are available, the dynamic scan gives further information, uroflowmetry along with EMG with surface electrodes. The invasive component is the cystometry, which can be artificial fill or natural fill, with facility for screening and fluoroscopy, with EMG for urethral function and urethral pressure, along with urethral pressures. The EMG here is included in the invasive components because needle electrodes are invasive in a child. The urethral pressures, as far as I'm aware, is not a very common practice in pediatrics. However, it is available. A simple frequency volume chart with which we are familiar. This is the format which we use, where there's recorded amount and nature of fluid intake, frequency of voiding, and the voided volumes, along with the opening of the bowel information. Simple uroflowmetry. Some of the uroflowmetry flow curves I've just put up. The top left-hand one is the classical staccato, the fractionated, which is indicative of dysfunctional voiders, the plateau, as which we are aware on the top right-hand corner, in obstructions, and the plateau with a bit of staccato associated was in a boy who was a late presenter posterior urethral valve. The invasive component of urodynamics, the cystometry, which is a pressure-volume relationship both during the filling and emptying phase of the bladder, where during the filling phase we focus on sensation, detrusor function, and bladder compliance. During the voiding, we study the detrusor pressures and urethral function. Along with the EMG, we get information of the pelvic floor activity. Associated fluoroscopy is used to look at the bladder outline, the outflow, which is the bladder neck, urethral outline, and sphincter activity. We have to keep in mind that the radiation exposure to these children should be kept at a minimum, and this can be done by using the fluoroscopy at 30 to 50 mil filling intervals and to capture an event. Cystometry involves insertion of the rectal and bladder catheters, and this is not very pleasant for a child, and hence we have to make every effort to make the experience better or even pleasant for the child, and this involves having a very friendly environment and setup. This is the setup we have in our institute, and prepare both the child and the parent for this investigation. The experience can be made better by walking the child through the room where the study is going to be done to familiarize him, or have a folder which tells the story. And this is the environment in which we do the urodynamics. On the top left-hand corner is the entrance to the unit, and subsequently the processes of tilting the table, etc., is introduced to the child. It's important that there are several facilities, if you like, to distract the child in the form of DVDs, toys, comforters. The role of the play specialist cannot be overemphasized. Parental contribution to this study to allay the anxiety of the child is very important. Coming to the next question as to who needs it, basically the non-invasive urodynamics most of our patients would have already had, and the usefulness of that simple non-invasive urodynamics is that it is quite reassuring both for the clinician and the parents when we can confirm our clinical suspicion on the simple investigations. The invasive urodynamics ensures that the bladder is a safe storage organ. The indications to perform urodynamics is neurogenic bladder of varied underlying etiology, posterior urethral valves. We have a protocol that we follow, and we perform the urodynamics at age 5 and 10 years and subsequently as clinically indicated. A severe refluxer, anorectal malformation, the neurogenic bladder in the high anorectal malformation group, a select group of patients with voiding dysfunction who do not respond to conventional conservative management, and in children who are due to have renal transplant, it's very important to recognize that the bladder needs to be a low pressure storage organ prior to putting the graft into it. We have to keep in mind that we should do urodynamics with a specific clinical question in mind. Some examples, I won't go into the details because subsequent speakers will refer to this. This was a 12-year-old girl with Spina Bifida who was managed with anticholinergics and clean intermittent catheterization, who was not really compliant, and who presented with a new symptom of leakage of urine and wetting. Her cystometry shows a raised baseline pressure, Detrusor overactivity, as can be seen from the graph, and not surprising, she presented with leakage of urine. Caudal regression syndrome. This is a 3-year-old little girl who had recurrent urinary tract infections and who really didn't pass urine in a stream. She just dribbled. Her MRI scan showed truncation of the spinal cord, which is seen in caudal regression. Her urodynamics showed that her upper tract held far more than her bladder, and her baseline pressures were also raised. This was a little boy who had a psychoamniotic shunt put in prenatally for bilateral hydroureteronephrosis and incompletely emptying bladder. Postnatally, the diagnosis was confirmed, and he had a classical appearance of posterior urethral valves. He is awaiting renal transplant, and his urodynamic cystometry showed a small capacity bladder with Detrusor overactivity. Another 20-month-old boy with severe reflux who just wouldn't empty his bladder. He's got a very floppy bladder, and cystometry has shown that. Coming to the question as to why we do it, of course, the aim is to preserve renal function and to maintain a healthy bladder to provide continence for these children. Just a reminder that the second most common cause of death is due to renal causes. This is a study in adults with Spina Bifida. Recently there was a statement in UK for the minimum standards to allow urodynamic practice. And we as a group of pediatric urologists, which in the British Association of Pediatric Urology, we conducted a survey just to get an idea of what exactly is the practice of urodynamics in our country. And it was a questionnaire, 19 institutions responded, and it was interesting to see that pediatric urologists were involved in many centers. There were others performing the urodynamics as well. The annual number of cases done in any given institute were about over 50 to a maximum of less than 150. And certainly in our institute, where we have a good team performing the urodynamics, including a dedicated pediatrician interested in bladder pathology, we do about 150 per year. Just before leaving to come to India, which is always a very good thing to do, to come to Matrubhumi as we call it, the night temperatures dropped to nearly -7, and from a very cold country, a warm thank you.
The next speaker is Sujit Choudhary. His key conferences improvement problems of pediatric urology.
I must admit that I'm feeling a bit out of place in this august gathering of pediatric surgeons and pediatric urologists. My association in the urodynamics is my interest in blood dysfunctions, and because of that we do sometimes manage pediatric patients, but now in our own institution the pediatric surgery department has started doing their own urodynamics. The issue which always comes with urodynamic practices is what is urodynamics and does it really make a difference to the ultimate practice? I still, after probably doing urodynamics for more than 20 years, and I still wonder this question whether it is a science or it is still an art. I guess jury is out to decide on that. But basically, simply stated, what we are trying to do is to apply the principles of hydrodynamics to the process of micturition. We are trying to study the storage pressures, the voiding pressures, and what's happening around it. Then how does it make it different when it's a child or an adult? The machine remains the same, the transducer remains the same, the saline remains the same. So what is the difference? I think the difference is because child is not an adult, and I don't have to tell you to this audience. But these features particularly need to be remembered all the time when we are actually tailoring a study for a child. The bladder is like, in younger children or infants, appears like an automatic kind of a bladder. It just fills up, and people used to believe that it is just happening at a spinal level, but now we know today that's not true. There is an arousal happens even in an infant before he voids. The only difference is that arousal is very subtle. It may be just a movement, and he goes back to sleep again. And it appears as if the volume triggered or the threshold of a particular volume, but it's not probably true. And the exact weight and the variations which are so much in children that needs to be kept in mind especially when we are interpreting the results of pediatric urodynamics. Then the other thing that happens is the capacity. Slowly it increases, but obviously it's a non-linear relationship, and usually reaches a reasonable volume by once the child reaches by about 12 to 13 years. But by 5 years, I think most of the children can. Same thing happens to pressures. The voiding pressures are higher, maybe because of some dysenergia movements which occurs, which again may be physiological. So these changes are definitely important, apart from the fact that the transition of a child voiding to an adult occurs with overlaying of the so-called cortical inhibitory influences over the sacral micturition center, and there is an evidence that the infantile reflexes still persist and can get unmasked during an adult life and may be responsible for some of the problems which we see later in the adult life. So urodynamics is a very simple word, but actually it's not one test. It's a battery of tests which includes, in my opinion, even the frequency volume chart or a voiding diary, which is a very, very essential part of an evaluation, but more so, of course, in adults than in children because it's sometimes very difficult. But the armamentarium includes uroflowmetry, assessment of residue simultaneously, cystometry, which has a filling and avoiding component, and the various reasons why we use them. And the main reason is we want to, as alluded by the previous speaker, we want to know, is this children's bladder safe? Can it store urine at a rate? It's very commonly seen that people are very fascinated by high voiding pressure, but one must remember that you void probably 4 or 5 times a day, an infant may void longer, but the maximum time spent by bladder is during filling. So it's the filling pressures which are far more important to upper tract damage than an isolated high voiding pressure which occurs maybe much less frequently. So one of the very, very important part of urodynamic evaluation, especially in neurogenic bladders and posterior valve, is the filling pressures. They are very important, and as we see go along. Now, as alluded already, that basically we have, as far as I look at it, there are 3 types of children when we do urodynamics. A child with a known neurological disease, where we want to know the effect of neurological dysfunction on the bladder. Second are the children who have known neurological diseases and they have bladder dysfunctions like posterior valve, reflux. And the third, children who have lower tract symptoms but are completely physically normal, and we cannot find anything wrong with them. And then we have a history of labeling them as Hinman syndrome, non-neurogenic bladders, and today dysfunctional voiding. And hopefully, the way things go, I won't be surprised if this terminology gets further changed in next 3 to 4 years, because frankly, we don't understand this particular problem. This is our simple data that which tells you that we have a very minimum experience. Of course, these all cases will get referred to us. We do kidney transplants, and some of the time we need to do to make sure that the children have safe bladders. So, but as you see, the maximum indication in our practice still has been neurogenic bladder. Now, you cannot, whenever you have to think of any urodynamic study, I don't think you should do a urodynamic study unless you know what you are doing for. Because if you don't know what you are investigating, and just because patient has a posterior valve, you do a urodynamic study, I don't think you will get an answer. I think the famous strategy that you put rubbish in, you get rubbish out, and that is significantly true for any urodynamic study. So you need to know by the proper history, physical examination, you must have reviewed all the imaging studies, and then the clinician must, in my department, when I see a clinician refers a patient for urodynamic evaluation, he has to specify what is his urodynamic question, what does he want the urodynamist to answer. And unless that question is put, we send back the request saying, please clarify why you want urodynamics. Because unless you do that, I think it will not fetch you the correct result. So this is all has been dealt with, and I don't think I have to do about it. The flowmetry is going to be talked about, but the most important thing is it's a very simple test, very simple to perform, but not in children who are not toilet trained. Obviously, you cannot get a child who is not toilet trained to do a flowmeter. But apart from that, the older children, flowmetry is very useful. As an adult, it's a screening tool. It tells you that if the flow is abnormal, then you need to decide why is the flow abnormal, and if you need further answers, then you need to proceed for invasive studies. At the same time, whenever it's a simple investigation, it is equal chance. There is always a chance of it being abused. And it is significantly abused in adult practice because people don't understand it. They don't even look at the volume which is voided. One of the most important questions we ask, or we must ask an adult when we come with a flowmetry, is that, is this your best performance? If the guy says, no, I was very upset with the room, or the nurse forced me to pass, that flowmetry is not conclusive and should be repeated. There's no point in looking at the machine result, which gives you sometimes the kicks of the machines. The patient has kicked and the flowmetry is recorded as 50 mils per second, or reverse. You cannot interpret a flowmetry in isolation. So you must have this. Was it the best performance? Obviously, in adults, they say you might need to do minimum of 3 and takes the best performance of the 3 as the representative of flowmetry. It should always be combined with assessment of post-void residue, and so that it has a far more clinical utility in deciding what to do on these children further. Recently, this is getting popularized with, especially in more for the pediatric children, because you can get a surface electrode EMG done, and so-called dysfunctional voiders or problem with blood flow activity can be picked up. I must admit that I usually do not do EMGs in my routine adult clinical practice. I'm not very happy with them. I personally get very impressed when sometimes I share these book pictures of fantastic EMG traces. They're not that easy to do, they're not always easy to obtain, so I usually rely on a video which gives you the same information with EMG. But this is getting popular, and I think the reason is very simple, that is non-invasive, and it probably works as a middle ground between presumptive management and invasive diagnosis, and can also be helpful for basically biofeedback purposes. I think I will pass on this because the next speaker is going to talk about flowmetry. So, and about the invasive urodynamics. The purpose, why do we do them? As alluded earlier by the speaker, that is basically to figure out the bladder's safety. Now, what is this bladder safety? What is the zone called safe period? Now, we know that the bladder compliance arbitrarily has been fixed as 10 ml per centimeter. Anything above that is considered normal. But persistently elevated filling pressures, say in the range of 25, 30 or 40 centimeters, are deleterious to the upper tract. And the entire purpose of urological management is to get the safe period increase to an interval. Either the patient can void or can catheterize. So maybe 3 to 4 hours. So you need to obtain a filling zone which will go from say 10 to about 20, 25 or less than 20 with the help of anticholinergics or CIC, and the child has at least, or an adult has a time of 4 or 5 hours that he can hold on urine. So that is, and that's why we say it's like a reflex hammer. What the neurologist uses for, the urologist uses CMG to, especially in the management of neurovascular dysfunction. What about the procedure? The problem with children is catheters. Nobody likes catheters, and children is unlikely to be, especially when they are above 2 years of age. They hate catheters. The sight of catheters start crying, and there are situations when, despite of all the help and taking them tour around and play, they just don't allow you to do that. Inside those limited situations, you may have to resort to a suprapubic catheterization under anesthesia, and what we usually do is quite a significant number of them sometimes require a lower tract endoscopy. So at the same time we use a cystocath and put a double lumen or the 2 catheters and do the study on the same day, preferably about 6 to 7 hours down the line, and they are usually very cooperative with that particular thing, but unfortunately it's an invasive procedure. Filling rates are extremely important because they can modify the responses. This research from ambulatory monitoring actually surprised us, because we all believed that the natural fill should not pick up more overactive bladders, but the ambulatory monitoring studies in normal adults showed that normal filling actually picks up far more detrusor overactivity than conventional even a slow fill cytometry, indicating that this artificial fill can actually suppress the detrusor activity. So it's very, very important to remember this, that filling would affect bladder responses. And so basically you try to go as low as possible, basically 10% of the total bladder volume at that particular age. Formulas are well known to you, and to make sure that you fill them slowly. Compliance is assessed, as I said, and the most important part is to make sure that so-called the Maguire's leak point pressure, which has been as 40 centimeters of water, have been proven to be detrimental. But I would say don't get carried away by the numerical. I want to know, is 35 safe? Answer is no. Answer is not a particular reading. It's a volume specific relationship which changes continuously. So if the volume specific relationship with pressure is changing frequently, that itself is dangerous, even if the infilling pressure is only 30 centimeters of water. So that is what must be remembered. So do not go by values. They are not important. It's a clinical decision, and the patient's other parameters which are far more relevant in interpreting urodynamics than isolated values given to you at the end of the study. Obviously it's an invasive study, obeying commands, which is a big problem in children, and it's an art to get to a good urodynamic study performed. If you know by the previous imaging studies that there's a vesiculatory reflux, you must know that it will alter your compliance findings. You may get a usually appearing compliant bladder because the whole volume is going into the bladder. We in fact had a case reported in Indian Journal of Urology where they were doing a urodynamics and they didn't realize they infused a large amount of fluid and they were not understanding why it's happening, and it ruptured. So, this was a non-video study. I guess it would never have happened if somebody would have done a video study, but they did not look into this issue. So it's very, very important. I have had patients refer to me for ruling out overactive bladder in the children. What we found is a bladder stone, because they never actually had done a KUB. So sometimes people get very, very impressed with urodynamics, and I think that's a mistake. Urodynamics does not replace basic sound clinical medicine, and it only comes as a complement and not as a video CMG is a Rolls Royce. We have it, but it should be done with caution, as already been said, but it's very, very useful, specifically in complex situations. When you are dealing with a complex situation, with a neurovascular dysfunction or a complex dysfunctional voiding, then yes, the answer probably is in a video urodynamics, and it's an extremely valuable study. Ambulatory monitoring, very limited data on children. I'm more aware of the adult data, but it's extremely useful in certain situations of complex incontinence. When you have not been able to figure that out, sometimes ambulatory monitoring helps. Many times the detrusor overactive, which has never been picked up by conventional, has been picked up by ambulatory monitoring, and it correlates with the incontinence because the child or the adult is wearing a nappy pad which is electronically recording what is happening along the 24 hours. And it's an extremely useful test, but in a very, very limited situation. But the problem which we have with pediatric as well as adult, the overlap between normal and abnormal is not very clear, so it should be very interpreted very, very cautiously. As I keep telling every time to my residents, that unless you have followed the basic so-called good practice of urodynamics, you will get wrong results. Your calibration is wrong, you don't know what catheter you are using, the size of the catheter, the position of the patient, everything to be mentioned. Your calibration of the equipment is the most important thing. If you have calibrated 0 not to the atmospheric but to the after putting the catheter, the entire your study is invalid. The International Continence Society wants you to 0 the pressure to the atmosphere, not by connecting it to the bladder. I've seen this mistake being done many times by many people. So it's important that you need to follow a very standardized protocol every time so that you get standard results. Otherwise, studies between 2 people or 2 centers will be difficult to compare. What is the most important thing which a urodynamist learns? When do you say that you are an experienced urodynamist and you can probably report? And I asked for this question to one of the persons when I worked in UK at Freeman Hospital, and he told me, Nitin, the day you learn to identify artifacts in your study and interpret them, that is the day you can say that you learned to understand urodynamics. I asked him how long it takes to do that. So he said, my conservative estimate is that at least you need to do 500 CMGs to be able to pick up artifacts clearly. So that's an answer. I think you need to be artifactually. Thank you very much for your patient hearing.
Very happy to be here. This is how my country looks at this time of the year. So I can appreciate the warmth here. Well, I'm going to talk about lower urinary tract terminology. I got into this business somewhat reluctantly because I think terminology is quite boring, but it's also quite important actually, because we need to speak a common language. And so I will walk you through the ICCS terminology, which is now quite globally accepted. So I will give you some historical background. I will show some of the problems that have been common and are still common about which words we use, and the way we in the ICCS have been trying to solve this with a new ICCS terminology. So in the beginning, enuresis was a word for bedwetting, or just wetting. It could be diurnal or nocturnal. And nocturnal enuresis meant bedwetting, and both were thought to be psychiatric disorders, as you can see illustrated by this quotation from Sigmund Freud. He was wrong in this case. Then came the Great Danes, and they discovered that nocturnal polyuria may be causative around bedwetting. And after that, we all thought that there are just 2 kinds of wetting. There is a complete coordinated urodynamically normal voidings while asleep in the child with nocturnal polyuria, and this we called enuresis. And then there was the wetting due to uninhibited detrusor contractions occurring during daytime or day and nighttime, and this we called incontinence. because we thought we knew that the voidings were urodynamically normal or when they were not. We were wrong. But consequently, the old terminology stated that nocturnal enuresis means complete urodynamically normal emptying at night while asleep, while monosymptomatic enuresis was bedwetting without daytime incontinence. And bedwetting in a child with daytime incontinence we called nocturnal incontinence, not enuresis. Please forget this. Then came C.K. Young, who's sitting there, and he showed that the nocturnal voidings of bedwetting children, they need not be urodynamically normal at all. And then came the Ghent group, and my wife, obviously, and they pointed out that monosymptomatic enuresis is often actually not monosymptomatic at all. And then came a lot of other people, and we all gradually came to understand that monosymptomatic enuresis is seldom truly monosymptomatic, and not all bedwetters have nocturnal polyuria. Many dry children have nocturnal polyuria and thus nocturia. And sleep is just as important as the bladder and the kidneys in enuresis pathogenesis. And also there are links between psychiatry and bladder problems. Then the lower urinary tract terminology for the adults was updated by the ICCS. And for instance, the term bladder instability was changed to overactive bladder. The pejorative term lazy bladder was dropped. Bladder capacity was changed to voided volumes, etc., etc. So it was time to revise the terminology, and these are the persons behind the document which resulted. Some of them are in this room. Because we knew that a new terminology was needed, just to exemplify some confusing situations. Like enuresis, according to the old terminology, as I just told you, it was meant to be a complete and urodynamically normal voiding, etc. This actually requires invasive investigations, that is ambulatory cystometry, to prove if that's the case or not. And now we know that even isolated bedwetting does not necessarily mean complete and urodynamically normal voidings. And monosymptomatic enuresis, according to the old terminology, meant enuresis without daytime incontinence. But what about urgency, straining, holding maneuvers, etc.? These are surely relevant symptoms. And then there's an eternal problem about voiding dysfunction. In my country, or in most European countries, when you say voiding dysfunction, you mean dysfunction of the voiding phase. That is, children with the staccato curves in uroflowmetry. When you talk to an American, voiding dysfunction can be an umbrella term for any kind of bladder dysfunction, and then dysfunctional voiding is not the same as voiding dysfunction, and that turns very confusing, at least to me. And as you know, the adult terminology has been changed, and we should follow so we can cooperate with the adult urologists and so on. So now to the terminology after these preliminaries. Incontinence, we subdivide that into continuous dribbling incontinence, a term that is relevant for all ages and which is associated with malformations or sphincter damage. And then we have intermittent incontinence, which is a term relevant for children 5 years of age or older, and that we subdivide into daytime incontinence and nocturnal incontinence, and we now make the term enuresis synonymous to nocturnal incontinence. So enuresis is the same as nocturnal enuresis and is the same as nocturnal incontinence, and all these terms just mean bedwetting, regardless of the presence or absence of daytime incontinence, regardless if we think the voidings are normal or not, or regardless if we think the cause is polyuria or something else. We need to simplify this so that everybody can know what words to use without having to make invasive investigations. And monosymptomatic enuresis, we now mean enuresis without any other relevant bladder symptom, like urgency, incontinence, increased or decreased voiding frequency, voiding postponement, holding maneuvers, etc., etc. This is more logically appealing, I think. And secondary enuresis is enuresis in the child who has previously been dry for at least 6 months, and primary enuresis is enuresis without such a preceding period of dryness. But this has often been overemphasized. We always talk about PNE this and PNE that children with primary nocturnal enuresis and secondary nocturnal enuresis, they usually should receive exactly the same treatment and the same evaluation. So the important subdivision is between monosymptomatic and non-monosymptomatic enuresis. Primary and secondary is less important. And then we have leakage terminology during the daytime, and urge incontinence is incontinence plus urgency, extremely simple. And voiding dysfunction, sorry Americans, we take that to be synonymous to dysfunctional voiding, and that's a term applying to the voiding phase only, not a term for any kind of bladder disturbance. And overactive bladder means just the presence of urgency symptoms. These children often have increased voiding frequency or incontinence, but that's not necessary for the definition. Detrusor overactivity, if we use that term, it means that we have made a systematic evaluation. And we don't speak about instability anymore. An underactive bladder means decreased voiding frequency plus the need to use raised intra-abdominal pressure to be able to void. And again, if we say Detrusor underactivity, it means we have made a cystometry and we have observed poor Detrusor contractions. And we don't talk about lazy bladder because that's not a neutral term. Voiding postponement is the observed habitual use of holding maneuvers to postpone micturition. The reason for defining this term is that in many studies this condition has been associated with increased psychiatric comorbidity. And then the volumes. We have followed the terminology of the ICCS, and we don't talk about bladder capacity unless we have measured the urine volume actually inside the bladder. We talk about voided volumes. And the term functional bladder capacity is thus substituted with maximum voided volumes, and we go after a voiding chart to find these values. But sometimes we need to compare these values with some kind of normal standard, and then we use the common formula, 30 plus 30 times H milliliters, to get some kind of standard for comparison, and that we call expected bladder capacity. So these are the various conditions you can have, and mind this is after we have simplified the terminology. It's still quite complicated. Most children with daytime incontinence have urge incontinence, and all children with overactive bladder, all children with urge incontinence per definition have overactive bladder because the sole defining symptom of overactive bladder is urgency, etc., etc. My final take-home message is that monosymptomatic nocturnal enuresis means enuresis without any other bladder-related symptoms, not just daytime incontinence. We should only say dysfunctional voiding or voiding dysfunction when we're talking about the voiding phase. We should not say bladder capacity when we have only measured what comes out of the bladder. We should not say diurnal enuresis. And the Vikings did actually not have horns on their helmets. That's 19th century romantic invention. Thank you.
Can I now invite Dr. Patil?
It's a great honor. The idea behind this particular presentation is to show how exactly you would go about looking at a Uroflow and making sense out of it. I've strictly adhered to whatever terms have been produced by the ICCS. It's the simplest of urodynamic investigations. It's non-invasive, inexpensive, and this has been repeatedly emphasized by everyone else. It is often used to decide whether invasive urodynamics is warranted, and of course it can be repeated to assess the effective treatment. So before, during, and after Uroflow, there are a number of things that need to be done. This is often neglected. You have to maintain a frequency volume chart for 7 days if possible, but if both parents are working, I find even 48 hours is difficult to do. You must ask the child to drink a little bit of water before the study. The child should be old enough, I think Dr. Nitin Kekre said that, should be able to cooperate by voiding on command. I find this term toilet training to be very variable. I think there is a civilizational gap between the East and the West in toilet training, as most of us in India will tell you. If our children are not toilet trained before 1.5 or 2 years, the parents get very upset because the child goes to school by 3. So the child should be dry by 3. After voiding, measure post-void residue by the ultrasound, and a real-time ultrasound has been recommended by the ICCS. It is important for the parents to have an idea of what exactly is happening, how much of void is being done, what is the volume of void, a rough idea of what the fluid intake is, if there is a leak, how many, changes, how wet, when, and the bowel frequency. In all this, we should not forget that constipation is an integral part of wetting. And this again forms an addendum to the ICCS document, and particularly because there is a large group of people who are here in this audience, it's important to remember that chronic constipation is also very much a part of wetting, and we must have an idea what exactly we mean when we say chronic constipation, and this is the Paris Consensus on Childhood Constipation Terminology group. Less than 3 bowel movements per week, more than 1 episode of encopresis weekly, a large stool in the rectum or palpable on the abdomen. That's a very simple clinical examination that can be done. Passing large bore stools that are difficult to flush, a display of retentive posturing, painful defecation, and 2 or more over an 8-week period. Please remember that in infants, only 1 void out of 4 is to completion. Therefore, in infants, measure how many voids, the residue after voids by ultrasound. And to measure, it's worthwhile measuring day per weight to assess the volume of the void. So this is the Uro Flow Curve that we are often presented with, and just to have an idea what exactly it represents, it's a bell-shaped curve which gives you the following. The following are looked at. The one is the maximum flow rate. Half of that forms the average flow rate. The area within the curve represents the voided volume. The time to take to hit the peak is called the time to maximum flow, and the flow time is the total time that's taken to complete voiding. That's a standard textbook description. Now, what do we look for in a Euroflow tracing in a child? We look at the age and sex of the child. We look at voided volume. It's preferable to have a good voided volume, though I don't know whether the number of 100 is correct. We basically look at only 2 things, the maximum flow rate and the shape of the trace. Now, as clinicians, we are often very happy to have some sort of figures that we can hold on to, and this is from the Journal of Urology 2005, which came out with these sort of normal values for maximum flow at various ages. Very hard to remember. It's very, very hard to remember. And I think the ICCS has simplified this enormously. There is a correlation between the amount of volume voided and the maximum flow rate. And therefore, for any given void, if you look at the square of the maximum flow rate and you find that it is equal to or exceeds the voided volume, this flow rate is probably adequate for the child. And that simplifies matters enormously. And again, the shapes of the curve that you can see has been again simplified by the ICCS. And whenever you report the shape of a curve, you have to do it according to the terminology that's been given. A bell-shaped curve, as I said earlier, is a normal curve. A tower-shaped curve would represent an overactive bladder. A Plato-shaped curve, which Dr. Kalpana Patil showed, represents organic outlet obstruction. A staccato or an irregular curve, which both previous speakers showed, shows that the sphincter is acting intermittently during the voiding phase. And an interrupted or a fractionated void represents voiding by Valsalva. So these are the various curves. This is the normal bell-shaped curve. The volume of the void is given there, and that's 294, and that's your peak flow value. So the square of the peak flow value, if it is equal to or exceeds the total voided volume, then that peak flow value probably is normal for this particular age. At the same time, we have got a pelvic EMG trace here, and that shows attenuation, which is normal during voiding. And this is the tower curve that you see in a child who's got an overactive bladder. Normally, there is a lag phase between starting the void and hitting the peak. But in a child with overactive bladder, the peak is achieved much more quickly. So that shape of a curve is what is called a tower curve, which represents an overactive bladder. And this is the Plato curve, where you have a prolonged void. The voided volume here is quite a lot. It's about 300 and odd, and the peak flow is about 9. So this is a grossly inadequate peak flow, and this represents voiding against some sort of outlet or outflow obstruction. And this is the staccato or an irregular curve. You have a curve which has a sawtoothed appearance. But before you call something as a staccato or an irregular curve, it is important to remember this particular definition of the ICCS, which says that the fall in the flow rate should be more than the square root of the maximum flow rate. Let's go back to this. I took up medicine hoping that I wouldn't have to deal with numbers and mathematics, but this confuses me. But anyway, here the maximum flow rate here is 43. Let's keep it at about 36. I'll explain to you why you can't take this as a good peak flow rate. This is again according to the ICCS. If you keep the maximum flow rate as 36, and if you have the square root of that, which is 6, then this fall that you see here should be more than 6. If you remember that each component of this is 12.5, 25, 37 during voiding. It's important to remember this, and it's also important to remember that you have to distinguish between a staccato or an irregular curve, which represents voiding dysfunction, and an interrupted curve where this void touches the baseline. We'll see an example of that later. So before you call something a staccato or an irregular curve, you have to remember this particular definition of the ICCS in your interpretation. And this is the classic interrupted curve. This is a boy who's about 18 years old with posterior urethral valves, who's voiding purely by Valsalva. He's voided about 479, and you can see each time it touches the baseline. When it touches the baseline, it's basically a zero flow situation, and then he voids a small volume, then he voids a small volume, and he's basically voiding by Valsalva. So whenever you call something an interrupted flow, you must show that the flow has touched the baseline and there is zero flow at that particular time. So the measurement of peak flow according to ICCS should be in a period when flow is sustained for at least 2 seconds. I think Nitin was talking about it, the recognition of artifacts. Suppose you get a curve like this and the peak flow values is shown as being around 50. The peak flow has been calculated at a time when there is an artifact in the flow. So what the ICCS document is saying is your peak flow should be calculated at this particular time when the flow is sustained for at least 2 seconds. So that's a very important thing to remember. If the volume of void is insufficient, what do? The simplest thing is just repeat the study, and I'll give you an example of that. This is a 7-year-old child who initially voided about 48 mils. That's about a 48 mil void. The child was asked to void again, and that's a much better void, and which changes a lot of values that we would use for interpretation. So if in doubt, repeat the study, and as Nitin emphasized, sometimes it's worthwhile doing it even 2 or 3 times. It basically requires a lot of patience to do it. Post-void residue. In the adults, 10% of expected bladder capacity per age is accepted as a post-void residue, and the ICCS is very clear that this cannot be applied to children across the board. It depends basically on the time when the ultrasound is being done after the uroflow. If the ultrasound is done more than 5 minutes after the uroflow has been completed, from the residual volume, you'll have to subtract about 1 or 2 mil per minute to get a very accurate idea of what the post-void residue is. Can we place a numerical value on the post-void? I'm a little unclear on that. The ICCS document also is not very clear on that. Perhaps, the various people in the audience can speak about this. Somewhere between 5 to 20 has been said to be okay. I think 5 is acceptable. Anything above that, you have to interpret with caution. But as I said, the time of the ultrasound after the uroflow has been done is pretty critical to decide how much of residue you should take. Now, Uroflow EMG, all the speakers previously spoke about Uroflow EMG. It's a non-invasive test which demonstrates abnormal contraction of the pelvic floor during voiding and can also be used as a biofeedback tool to unlearn this abnormal pelvic floor activity. Now, this is the ICCS stand on Uroflow plus EMG. If available, the addition of pelvic floor EMG adds to the value of Uroflow in children, and EMG at best gives only an estimate of urethral function in children. We are talking about Uroflow, we are talking about EMG being done with patch electrodes, not with needle electrodes. So the methodology are children are asked to drink water till their bladders are full. Surface electrodes are placed at the 3 o'clock and 9 o'clock positions on the perineum, with the third electrode on the thigh to measure leg activity, and then we ask them to void. And as Nitin said, these are quite nice to project but extremely hard to get. And this is a 12-year-old who's got a very nice bell-shaped curve, who's got a very good volume of void, who's got an excellent peak flow activity, and a complete attenuation of the sphincter activity with a post-flow reinforcement of his EMG activity. And that sort of attenuation during the void is what we are looking at. But these sort of traces are far and few between. And again, this is the plateau curve that I showed you before, a very long, prolonged void, a void of about 300, a peak flow of 8, which is completely insufficient, an extraordinarily high pelvic floor activity during the period of the void, which indicates that there is obstruction due to the void. And this is a very clear case of dysfunctional voiding. Now, I'm asked this question repeatedly. I try and talk to pediatricians. I talk in various forums, and this question is repeatedly asked. I think Sujit himself would have asked me this repeated so many times. In a dysfunctional void, is Uro Flow EMG always necessary? And the answer is you don't really have to do it. I mean, if you have somebody who's got a very classic symptoms of incontinence, I mean, I think Tim will get angry if I say wetting, and who's got constipation, who's got a palpable sigmoid colon, and you know that this child is has got definite voiding dysfunction, do you really need to do it? But we find that it's very useful to explain to the parents exactly what is going on. I'll show you one case example. This is a child who had a documented urinary tract infection in the first year of life, had a DMSA and an MCU done, and that's in 2003. And you can see the smooth bladder and both the kidneys on the DMSA being normal. Child was commenced school at 3 years of age and strictly instructed by the mother to hold urine in school because she felt a child can pick up infection from the school toilet. And school toilets being dirty is a feature of life. At 8 years of age, the child was severely constipated, had a significant leak, was smelly with no friends and stood in holding posture all the time. And that was the MCU and the DMSA at 2008, showing pronounced neurogenic changes in the bladder with left-sided reflux and a severely scarred kidney on the left side. And for us to explain to the parents what exactly was going on and how to explain to the mother that it was her insistence that the child not pass urine in school was the cause for this, Uro Flow EMG was quite helpful. And also as a tool to see what would happen if this habit is corrected over a period of time. Incidentally, I've always believed that this affects only the patients I see, and I see something like about 7 to 8 dysfunctional voiders a week. I must tell you this, and about 2 weeks ago we were traveling to Delhi and then subsequently to Lucknow for a conference. My wife and I were, we started at 7 o'clock from Chennai and we reached Delhi at about 4. We went to the toilet frequently at the airports. My 10-year-old did not. And I asked him what was going on, and he said he held urine all the time in school because the toilets were bad. Talk about divine retribution. So I think we have to basically talk to our children before talking to our patients. So in conclusion, Uro Flow is the most basic and easily done urodynamic test. It's easily interpreted if the ICCS criteria are remembered and appropriately applied. And in conjunction with ultrasound, it indicates when invasive studies are warranted. Thank you once again for the opportunity.
The next speaker is none other than Dr. Sujit Choudhary, who is well known to most of us. And he is a professor and head of pediatric surgery at Vellore. He will now talk on systometry, normal versus abnormal.
Thank you, Santosh. Now, what is normal? I think enough has been said about what is normal. I just give a very simple diagram. And one hand we have detrusor pressure, other we have time infused, which is a function of volume infused. And normally in normal children, it just rises a little bit only until the child reaches the expected capacity, which any formula can be used. This is a useful formula which we use. And the child voids. Now, I have drawn, so this part is called filling and that part is called voiding systometry. Now, I have just drawn 3 lines, as Dr. Nitin also said. Now, in most normal children, we expect during the filling phase, the pressure not to rise above 10. But everybody not absolutely normal. You can accept up to 20, but beyond 20 you get worried, and above 40 is absolutely unacceptable. Now it is useful to remember this only during the filling phase. During voiding phase, however, the pressures can rise normally do rise to quite a high levels, higher in males than in females, and in males it can reach 80, and females 60 centimeters of pressure. But that pressure doesn't seem to harm the bladder that much, because it is only for a few minutes, while this goes on for hours. So just with this simple graph, I'll proceed to the rest of my talk about abnormal cystometry. Now, I think it's very nice to understand what is the pathogenesis of abnormal cystometry. And in pediatric practice, often we find that it is a situation where the bladder faces an outflow obstruction. You see this gentleman going, and he finds the door locked. So he represents the bladder. Now he's got several options. Imagine yourself in that situation. Now one can start with polite knocks, and if the knocks don't work, you just start banging the door, but still intermittent. That we call detrusor overactivity. On the other hand, if that doesn't work, you start pushing the door, and very hard and sustained push, and that leads to a very stiff bladder, which is always a contracted state, and we call it hypocompliance, which may be due to the muscle in it, or in time the muscle gets replaced with collagenous tissue. Now after if that doesn't work, what we do is we just give up. We just sit on the chair and just wait for God to help us. And when it gives up, we call it detrusor failure, and where the bladder becomes floppy and the detrusor just doesn't act. Now the problem with the bladder is that once it picks up some of these bad habits, it tends to persist with it even after the door is opened. Or sometimes it changes from one bad habit to another bad habit, just like leaving tobacco and taking up alcohol. So it doesn't, generally the change is for the worse. The common outflow obstructions in children, I'll just deal with three. It can be functional obstruction, as we see neurogenic or dysfunctional voiders. We see structural obstruction, like post-urethral valves, or man-made obstructions, like repaired extrophy epispadias. So with these three examples, there are lots of other conditions. With three examples, I try to show how the bladder shows abnormal cystometry. Now, we must do an MCU before doing a cystometric study. And in I started neurogenic bladders first, because that gives us the basis of, the various abnormalities you see in cystometry in children. So the bladders, obviously these bladders all look very sick. But if we do cystometry, we may be able to pick up these bladders much before than this appearance which we see on MCU. So I'll just go through some cystometry graphs in our patients with neurogenic bladder. For example, this particular child, just look at the detrusor. Well, it remains fairly good, and then he starts voiding. The voiding is a bit intermittent, but on the whole, he can store urine at very low pressures, so he is a good one. The bladder has not undergone very bad changes. This is slightly worse. Another child, you can see the bladder fills up to here, it's sort of below 20. This first mark is 20, and it is okay up to about a volume of 200 cc. Thereafter, it starts rising. So therefore, the clinical implication is we will be able to prolong this by giving drugs, or if this interval is, this volume can be managed with, say, 4-hourly CIC, he is a candidate for intermittent catheterization with or without drugs. So this clinical information we are able to get from cystometry. There is another child with meningomyelocele. You see, he comes with incontinence, and as you keep filling him, the pressure rises tremendously. And not only does the pressure rise, there is lot of detrusor over hyperactivity, or we used to call it hyperreflexic detrusor in a neurogenic bladder, but that term has been given up. And so here the compliance is poor, and lot of detrusor activity, and it's probably the muscular component which gives rise to a very stiff bladder. In this particular child, the pressure is not rising that much, but there is again detrusor overactivity. And now I'm getting confused with the terminology myself. Detrusor overactivity, which causes intermittent contractions and leakage. Now this particular child, again meningomyelocele patient, she has, see, the pressure seems to be okay for a little while, and at a very low volume it rapidly rises, and then she starts leaking and the pressure rise falls a bit. Now here there is not much muscular action at all. It is probably a bladder which has become fibrous, like a collagenous sac, more like a paper bag which we buy. And the paper bags, as you know, you will able to fill it for a while, and then you imagine filling air into a paper bag, and it will fill okay for a while and then suddenly become very tight. So that's a very bad situation, and at a very low volume she is experiencing very high pressures, and then she leaks. I like to project whatever I see on cystometry in my mind's eye as to what the bladder is like. Now this particular child is not a meningomyelocele patient. He is a child with a mild mental retardation. He's not quite normal, maybe some sort of cerebral palsy or some antenatally or immediate postnatal event has happened. Now he came with urinary incontinence, and you see he fills, and then the pressure rises like a void, and he comes down to baseline. Again he fills a little bit, and immediately he voids, and we have to watch his voiding, watch him while he is going on, and you can see a very nice void coming at each of these spikes. It's like an ECG pattern. So that is happened because perhaps his bladder is not being inhibited by his brain, and therefore he is voiding at very frequent intervals. I don't know what the proper treatment for this would be, as perhaps training and will help him, but it is interesting to see that this pattern can change. He came after a few years with increased typical hypocompliant bladder, so situations might change. Now just a few case reports will give you better understanding of what is happening. Just to give you illustrative case examples, maybe just two per condition. Repaired meningomyelocele coming with incontinence, upper tracts are normal. This is the graph I showed you earlier. This child is leaking, and this is the pressure. So I thought that because his compliance is so poor and lot of muscular activity, I'll just give him anticholinergics and intermittent catheterization. And that worked very nicely. He came back after 2 years with no leak and absolutely flat curve. So that he has responded very well to anticholinergics and intermittent catheterization. His upper tracts were normal all this while. On the other hand, this child, again a girl with repaired meningomyelocele, she came with incontinence, upper tracts were dilated, she had major reflux and recurrent febrile UTI. With this combination, it's a bad combination, and obviously a neglected neurogenic bladder, and preoperative CMG showed a very rapidly rising pressure. So we decided this child is not for conservative management. We did an augmentation cystoplasty for him in view of the upper tract dilatation, major reflux and UTI, and everything resolved, and she's going to school and she's continent on CIC, and the cystometrogram shows the nice response to augmentation. So you have to choose the case. Now coming on to the next condition, post-urethral valves. This is case 1. Child, he was fulgurated when he was about 2 years old, and he continued over the next 2 years to have gradually rising serum creatinine, and the kidneys remained hydronephrotic. So and he also had dribbling. So the clinical question was, why is he doing so? He had a repeat cystoscopy, valves have been adequately fulgurated. So is the bladder playing up? So it is a CMG, and there is no reflux on the MCU, and the CMG shows a very rapidly rising pressure. So this child, we thought, may benefit from a augmentation cystoplasty, and that's what was. And he was put on oxybutynin for 2 years. He did not respond. This graph is after oxybutynin therapy. Post-augmentation cystoplasty and a Mitrofanoff, his curve has become flat, his hydronephrosis has come down, and both kidneys are not very mild hydronephrosis. And his creatinine stabilized for about 7 years, but now again slowly his creatinine is coming up, so going up. So we're just buying time by doing an augmentation. He's a much bigger child now, and sadly in post-urethral valves that's often the situation. Now again another child with post-urethral valves. Now you see the older child post-urethral valves often come with a huge bladder, incontinence and hydronephrosis, and sometimes UTI. Now when we made him void, his stream is not bad, but he is able to complete voiding only after 4 attempts. 400 ml, 75 ml, 85 ml, 45 ml and so on. So why is it that? Again he had a cystoscopy, there is no residual valve, and the CMG shows us his detrusor is not acting at all. He can keep on filling, he has no sensation of bladder fullness, and he doesn't show any voiding effort at all. So this is what we find that the detrusor has given up, is failed detrusor. So the treatment would be intermittent. We put him on intermittent catheterization and night drainage, and we'll see. There is after 2 weeks, hydronephrosis has come down a little bit, and creatinine came down from 1.7 to 1.4, and he is still on intermittent catheterization and night drainage. Now another role for CMG is in undiversion of diverted PUB. In our country, we still do a fair number of cases. We treat them with urinary diversion because it's a life-saving operation when they come with high creatinine and sepsis. And still, though a lot has been said against it, we still in our country do a lot of diversions. Now, when we undivert them, we fulgurate, and don't do it in one shot. We fulgurate and do a partial undiversion, and then go on to complete diversion. That has been the usual practice in many centers in India. But what I like to add is, between this stage and this stage, please do an assessment of the bladder, because this bladder is an untried bladder, and you don't know when you complete the undiversion, he might again go back to high creatinine status. So this is important. And how do we assess a diverted bladder is also tricky. That's why we do, without a partial undiversion, you cannot assess the bladder. When it's fully diverted, you can't assess the bladder. So partially undiverted, preferably with the worst kidney, and then go on to assessment. Now this particular child bladder has been partially undiverted. His creatinine was very high to start with. Now it's become normal, and you see this bladder shows detrusor hyperactivity. Though there is a lot of disturbance, but there is intermittent at the contraction of the detrusor. So we thought this bladder not safe to complete the undiversion. So we gave him 1 year of oxybutynin, and after that he's been absolutely flat. So we have completed the undiversion, but we don't know what we'll do. We cannot take off the oxybutynin, so we continued on oxybutynin, and we taught him night drainage to maintain his renal status. So fortunately, over the past so many years, his creatinine has remained normal. His kidneys show beautiful recovery on this regime of night drainage. Again, another child with a PUV partially fulgurated and partially diverted bladder. He had a unilateral refluxing ureterostomy as a pop-off mechanism, and PUV was fulgurated. Now he came for full undiversion, and when we did the CMG, he started with a very high creatinine, but the creatinine came down to 0.4 or so after this procedure, and we see that even after 1 year of oxybutynin therapy, his bladder shows very high pressures. As you fill it, it goes up to even 100 centimeters of water. So therefore we thought this child will go back to his high creatinine if we just close the ureterostomy. So we undiverted him with a bladder augmentation. I mean, it's very rarely do you have to do that, but occasionally you do. And that is the importance of checking the bladder before you completely undivert and land up with a problem. Now, extrophy epispadias as a man-made obstruction. So this is an example of a child, incontinent female epispadias, Justin Kelly operation. I'm sure many of you are familiar with it, and a Mitrofanoff performed. Any bladder neck procedure, I like to do a Mitrofanoff with it for safety. She was rendered continent for about an hour. She was absolutely wet before. Now every hour she could go to the toilet, and she came 2 years later for an assessment. I'll just show you. Her upper tracts have remained normal, but he shows the typical low capacity bladder. So you fill up, she voids, fill up, she remains at the baseline but she voids, and so on. We are reasonably happy with it. But she came back after 8 years with increased leaking. She used to hold for an hour, and then now every 45 minutes she has to run to the toilet because her Mitrofanov leaks. That I found very fishy. Why the Mitrofanov is leaking? She's not leaking from below so much. She rushed to the toilet and voids. And we did a CMG that showed the detrusor pressure continuously rising. So she has changed from a reasonably good detrusor to a high pressure situation, and we put her on oxybutynin now. She has not come again. This is a recent case. So this is what I say, that any man-made obstruction also the bladder can react very unfavorably given time. Another girl with incontinent epispadias. This is a pre-op, absolutely normal kidneys. We have done a YDL plasty, bladder reimplant and a Mitrofanov, and she is on intermittent catheterization. She is quite dry, but she came back with hydronephrosis. And the CMG shows very rapid rise of pressure. So we decided to do that. We cannot wait any longer. We did an augmentation for her. And after augmentation, the hydronephrosis has settled down. She's had a long follow-up over 7 or 8 years, and she remained normal. Another child, male child, extrophy, is one of the earliest newborn repairs I did a long time back. And later he had a YDL plasty and bladder reimplants, and she was continent for 16 years, one of the few patients who developed long-term continence. But now he came with persistent febrile urinary infection. And he has no reflux, and the kidneys are looking moth-eaten, and he has a tremendously large bladder. So this is another reaction to the artificial obstruction which we have created. CMG shows a very flat curve. Only solution is Mitrofanov and CIC. Just to conclude, when faced with the angry bladder, don't worry too much about what was it originally. Sometimes we find bladders which just come to us with some history behind. But it's important to assess them now and take a decision now on what's happening.
We call the next speaker, Dr. Kalpana, who will talk about case scenarios in the Indian context. Dr. Narasimhan is from the PGI Institute in Chandigarh. He has 10 minutes.
Good morning. Thank you, Sujit and Dr. Meenu Bajpai and Santosh. The Advanced Pediatric Center in Chandigarh is the largest hospital in the northern part of the country. It serves 4.5 states at least. The state of Uttar Pradesh and Haryana, Punjab and J&K. And the workload is unbelievably high because all the patients come here. There are no regional postgraduate referral centers. So it's a bit of a, I'm not doing total pediatric urology. I'm a part-time. I mean, I have to do newborns, I have to do everything else, chest also, but I have a great interest in pediatric urology. The hospital is the other one, the farther away building, and we got some facilities when we shifted there. Actually, two of these people are present in the audience. This is Professor Mitra. This is Professor Pathak, who started the department, and Professor Kale and Rao. Both, all of them are my teachers, and they were all also part-time pediatric urologists. Our practice is somewhat institutional and somewhat research-oriented. So most of the referrals are in some areas which I will discuss, and I would be focusing on not the case scenarios actually, but I will be focusing on the national scenario for the poorer lot of the country, how they come in this country. Neural tube defects is the major group, and this is because of an antenatal lack of adequate antenatal program and lack of national preventive efforts. It's not rare. It may be present in sporadic areas, but when the deliveries are not supervised, you have a lot of neural tube defects born. And these patients, most of them, 60% of the children in India are very poor. So they land up poor and wet and land up for surgery after meningomyelocele. And when I get a referral of this kind, I try to define whether there is a high risk bladder and whether they can be taking up prophylactic CIC, whether they have the resource to do it or not, or they have to wait for some time and go in for therapeutic, and some patients may accept vesicostomy. And after the child starts going to school, the aim is to keep him dry so that he can have a normal life like other kids. Occasionally we get referrals from neurosurgeons pre or post-op for occult sinus dystrophism, but I must be getting about 10 or 15 patients per year from neurosurgeons, whereas I get about 200 neural tube defects primarily. So most of the meningomyelocele in this country are done by pediatric surgeons, and who should be aware of bladder care. But unfortunately, either patient compliance is lacking or the patient is not explained the risks, and they come late. I think about 25% of the kidney transplants done, that may be a rough estimate only, in India must be due to neural tube defects. See, this is two brothers. Both of them have had meningomyelocele surgery, and I just thought when the mother came with both the brothers, I was a bit shocked that, the second child at least could have had a screening. These were operated and they had come for referral for incontinence to me. Look at this. This is a child who should have been antenatally terminated, but I am looking after his bladder now. So all the children I can't recommend the prophylactic CIC, because in some situations the home situation is such that they are living in a single room with 3 children, and this asepsis is not good, and if you start giving advice on prophylactic CIC as soon as it's diagnosed, they'll end up with breakthrough UTIs and it's a disaster. So I do advise according to the patient, and this is a big challenge which actually needs a lot of support from the government. So this is an unfortunate child who did not, who had a late antenatal scanning, had a huge lumbosacral meningomyelocele, very incontinent. The mother comes from a low socioeconomic status, but she understood the value of CIC, and she is meticulously motivated and following CIC. The child is dry now, has no breakthrough UTIs, has had stable renal functions now for 4 years. So it's not that every poor kid, mothers don't care, they do care. The patient profile is what is amazing. See, look, this guy, I think in Indian rupees he must be making about 2,000 rupees, and the cost of the oxybutynin, his child is 3 months old, and the bladder is a high risk bladder. The cost of oxybutynin per day is 20 rupees, that is 600. A third of his pay will go into just paying for oxybutynin. He can't afford it. He was telling me, I just can't manage that much of money for oxybutynin. This other child, the father has got only one child, so he is willing to pay for oxybutynin, though it's very difficult. So this is a girl who was referred for meningomyelocele at the age of 1.5 years. She had surgery at the age of 1.5 years from Shimla. Shimla is about 90 kilometers from Chandigarh, but the travelling distance is 2.5 hours because it's mountainous drive. So the patients, you can't ask them to come regularly. They will come once in 6 months or so. She has stable renal functions, ultrasound is normal, DMSA has got no scar, but she's all the time incontinent. So I did a cystometry. She had a high risk bladder, but there was no damage to the kidney, and she has been in great relief with oxybutynin and CIC. She's dry and she's able to go to school. So this is the picture. This is the detrusor contractions. You can see the detrusor contracting every 5 mL of water filling, and the same after giving oxybutynin. She had a fantastic response to oral oxybutynin. The other problem is our temperatures. Our temperatures in winters varies from 0 to 10, and in the summers it goes to 45 degrees centigrade. So the serious issue is tolerance to oxybutynin. We have a great problem, and I asked one of our trainees to do a study on tolterodone versus oxybutynin. It was the patients. If you just prescribe oral oxybutynin in summers, patients don't follow at all. They can't even take it during the night because the temperatures are in the night is 35. With an air conditioner they can take. But most of the patients don't have air conditioners at home and they can't manage. So the newer drugs are more efficacious in managing bladder in these children. These are occasional patients only. If you see such patients referred from the neurosurgeon, fantastic. In India, of course. This is a 6-month-old child who had a tuft of hair on the back, and the MRI showed a dural thickening here, and the neurosurgeon wanted to do some surgery on this patient. He referred me asking whether there was any bladder change, and he wanted to do surgery only if there was any change in bladder functions, because there was no neurological deficit was not there. The child had normal cystometry, and the child waited for some time. After a year, when the bladder changes started, I did a laminectomy. Later on, post-operatively, I had evaluated the baby. CMG was normal. One of the major problems I realized was our patients not being able to follow drugs. So I arranged charities from some of our old students from England. They paid for 2 years for all the patients' drugs. So I used to dispense the drugs, and we spent about a lot of resource and time, and all the parents who are regular would come down to collect the medicine and give a voiding chart that the child. The second largest group is ARMs, and these patients, if they have incontinence, they have to be assessed. So they come to me. Some of them come to me. Some patients operated in different parts of northern India with ARM who has incontinence. Sometimes sacrococcygeal tumors also come. Some patients, you see sacrococcygeal teratomas operated totally on a catheter for 2 years and 1 year, and then they come for they get referred, and it's very useful to do cystometry and then advise them, and they become catheter free and are able to go to school. Primary voiding complaints are very rare in my practice, and dysfunctional voiders also not many. I think Dr. Sripati sees a different profile of patients. In southern India, the profile must be very different. 7 voiding dysfunctions in a week is a phenomenal number. This is a child who had PSARP by 2 surgeons and had come for urinary and stool incontinence. He was a miserable child with a very motivated mom. And he had one side VUR with a scar in that kidney. Mother was motivated. She got cystometries done, and then he's on oxybutynin plus CIC, and he comes every birthday to distribute gifts to all the children in the ward. He is dry and enjoying his childhood like any other kid. Look at this sacrococcygeal teratoma. This is a huge one, and at least I think all these surgeons who operate these children should at least get a post-void ultrasound after surgery, and if the ultrasound is abnormal or there is high residual urine, they should get, or there is wetting, they should get a cystometry done to know whether there is any residual neurogenic damage. So most of these sacral agenesis I have seen are all having only lock of sensation to the bladder. Only a few of them have high risk bladders. There are a few voiding dysfunctions. This is a 13-year-old boy who came with suspected posturethral valves. DMSA had no scars. Ultrasound shows no hydronephrosis. MCU showed a dilated posturethra. Cystoscopy showed a normal posturethra, and the spine was normal. And this was his voiding pattern. I don't know, after Dr. Sripati's lecture, I'm a bit confused to call him staccato voiding or not, because I labeled him as a staccato voider, and this was his cystometry. The bladder was a low risk bladder, and I referred him for urotherapy. I just put it again because I got him to void 3-4 times, and every time he could reproduce. His bottom is not coming right down, I think. Am I justified in calling it? Okay, I've passed the exam now. Because I see Dr. Sripati nodding his head. This is a 10-year-old boy who presented with poor urinary stream and dribbling since birth. He was referred as posturethral valves with a scarred atrophic kidney, grade 5 reflux on the right kidney without scarring. His urea and creatinine were normal. MCU showed a dilated posturethra. Bladder was trabeculated. He was constantly changing his shorts because he was wet and was very smelly. He had a sacral agenesis. He could not attend school. Urodynamics showed a small bladder, high pressure with premature contractions, and he was put on tolterodone and CIC. He is able to go back to school. So this is his cystometry, which shows very high contractions, and I just put this chart to say that even the rural Indians are capable, even though it's not in English, they are able to maintain a bladder diary. This is a mother who is written it in native in Hindi, and she is able to maintain a 7-day bladder diary. This is 2006, okay? So it's not that the uneducated can't do bladder care, they can. This is an 8-year-old child from upper middle class, always wet in school, day and night time incontinence. Again, definitions I have to revise because ICCS definitions I just heard this morning and I thought, oh my God. He passes urine and semen in small quantity. He has fecal swelling for the last 1 year. No neurologic deficit, no spinal markers. Referred with with MCU and a diagnosis of PUV. Cystoscopy showed no valves. Actually, he had a very abnormal cystometry. When you fill the bladder volume about 80, 70 ml, till then it was okay, and then it shot up like that. I don't know what pressures it reached, I couldn't read, but he just emptied the whole bladder. He responded very well to oxybutyn. I have no idea what to classify him as. Every time I change the diagnosis, but he has responded very well to oxybutyn. This is a 3-year-old child with, again this definition is gone. Constantly wet, every time she will have an acute episode of pain, sit down and wet her garments. Had recurrent UTIs, MCU was normal, ultrasound was normal, DMSA scan, 1 pyelonephritic star in 1 kidney, normal renal functions. The post-void urine was about 10 ml every time. Diagnosis is questionable. I don't know what you will label this as. Again, she had 40 ml filling, the bladder would contract and empty. And she is on oxybutyn. She is able to hold the urine for about 2.5 hours and go to the toilet and empty. So she is not wet now. She is able to go to school. So the other group is extrophy patients who have been augmented with or patients who have got incontinent epispidus. That's the third group of patients I do have who come for assessment. This augmented patient, it helps me to decide how much, at what volume they should do a CIC, because the low pressure at which they should empty the bladder, I can decide on doing a cystometry. So the patients also understand then that they, by seeing the graph, that this is the safe time for which they can wait before they do a CIC. So actually these are all parts of the study which are all published. So when we have patients who have in neurogenic bladder, who have small bladder volume and high pressures, they are having higher chance of scarring. So they should be institutional bladder care introduced for these children, and it's a need of the hour in India. Actually, I have not discussed the case seniors because I don't want to educate this elite audience, but I have tried to focus on a few problems which we see in India. I think every children's hospital in India should have expertise in urodynamics, and there's a lot of work to do in this country because there's a huge population of children. And we need to know how to fund our children who are poor, the 60% of the children, and how to motivate these uneducated and semi-educated parents to give CIC and give them a life of dignity, which is the need. There is no dearth of children in India. And I just put this quotation on top that success is the ability to go from failure to failure without losing your enthusiasm. That's what these parents show us. They really have to struggle for their bread, and they still try to keep their child all right. Thank you for listening to me.
Dr. Sujit Choudhary doesn't read the introduction here. We all know him. The brilliant pediatric surgeon from Bombay and Lilavati Hospital, Dr. Choudhary.
Thank you, sir, for the kind introduction. Ladies and gentlemen, we've had a wonderful session in the morning, and a lot of things about neuropathic bladder have already been said. And so I'm going to be very brief. I don't think I'll take my whole 15 minutes, but I will just run through the various clinical scenarios that we encounter when we talk of neuropathic bladder or neurogenic bladder. As has been mentioned in the morning session, the incontinence bladders can be grouped, and I like to call them true neurogenic and false neurogenic. True neurogenic bladder is one where we can identify a neurological lesion, whether it's a low motor neuron or a higher lesion, but a neurologic lesion is identifiable. And these, as has been mentioned again in the morning, are a group of conditions where the neurologic lesion is not there or not identifiable. Maybe some of these, with the passing years, may go into this category.
The true neurogenic bladder can be classified further as those caused due to congenital conditions or those resulting from acquired conditions. The congenital varieties, and the commonest one in that is spinal dysraphism, of which we have the manifesta group, the lesions which are very evident, and the occult group, which comprises of the tethered cord, diastematomyelia, intraspinal cysts, syrinx, lipoma, and Arnorchiari malformation. We also have in this group the sacral agenesis and anorectal malformation patients, especially after their surgery, who may result in a type of neuropathic bladder. A rare condition, and of which I have not encountered a patient, but some of you may have, is the urofacial Ochoa syndrome. Going to the acquired type of neurogenic bladders, we can see them in spinal cord injuries, we can see them in patients with cerebral palsy who have, and we have a large number of these patients in India. Somehow we don't get a lot of these patients coming to us for their urinary incontinence and urinary problems. And I am in discussion with the Physiotherapists Association and the Orthopedic Association to recognize that some of these patients can be managed. CNS infections may result in acquired variety of true neurogenic bladder, and of course some tumors in the pelvis or tumors invading the spinal cord can also cause a variety of neuropathic bladder. Going to some clinical situations, firstly the very common condition of spinal dysraphism. A few points just to be highlighted is that the lesion, the neurourologic lesion in spina bifida, is an ever-changing one, and the dynamic nature must be recognized. And as has been mentioned in the morning, most children or almost all children are born with normal kidneys, but over time their urinary system may change and their urodynamics may become abnormal. So I think we have to recognize that this lesion changes over time in this group of spina bifida. And the growth spurts in these patients, as we know, is during infancy and during puberty. So they have a different kind of presentation in the newborn, a little later, and as they grow. So what is the first scenario we are faced with when we start thinking about a neurogenic bladder in spina bifida is, of course, the newborn with a meningomyelocele. And you can have a range of lesions, a small one and a giant bubble on the back. It is now believed that it's good to assume that all these patients will have altered urodynamics now or later, and therefore in the early infancy intervention is advised, intervention in the form of investigations and in the form of medical management by way of anticholinergics or CIC, early institution of CIC. And this is how the concept of medical augmentation has grown, and this was a term which I heard some years back, and I was very amused and fascinated by the term medical augmentation, because it's very true that if these group of patients are investigated early, treated early, and followed up and monitored, you may prevent a large number of patients getting a surgical augmentation. So that was one group in the newborn period, and there they may not have any obvious urodynamic problems or symptoms, but we assume and start treatment. But the situation changes in a girl who was born with MMC but then operated at birth and now has come to you a little later in life with obvious urinary incontinence. Then of course these children, the first thing you do is investigate them and start a CIC regimen. The mother can be taught or the father can be taught how to do the CIC. It's not very difficult, irrespective of the socio-economic conditions. I think if you take a little effort, it's not very difficult to teach them CIC. And of course these patients will need a full urinary workup. A word, when we say full urinary workup, I mean, we don't dispute the fact of USG and MCU. As far as urodynamic studies are concerned, yes, we've heard a lot since morning, and I want to say just one thing. A lot of urodynamic is still an art, and there was a mention about science and art of urodynamics. We are getting more and more scientific, but it's still a significant bit of urodynamics is art. So your experience and your evaluation, your history taking is equally important. In many of these patients who come to me with spina bifida, with a little elder group of patients, we do perform simple clinical bedside evaluation, which consists of these investigations plus a bedside measurement of pressures. And this can be done 2 or 3 times when they are admitted in the ward, and we try and find resting pressure, the importance of which has been emphasized by every speaker in the morning. We measure the random residual volume, the leak point pressure, and the bladder volume, if we don't use the word capacity. And of course these other tests are done. We collate, we put all this information together and arrive at a probable urodynamic conclusion. And I want to just mention here that a few years back, one of my postgraduate students, we did a dissertation with him where 25 patients of this time were sent for machine urodynamics, and the findings in an experience center, the same center did all the studies, and this conclusion was sealed in an envelope. And we did a clinical bedside evaluation separately of these 25 patients, and it was a double-blind study which was then compared at the end of 25 studies where both these were done. We opened the envelopes in front of 3 observers, and there was only one mismatch in the conclusions. So interpretation is not to be underemphasized. I mean, it's very important. This girl on which you saw in this picture then was investigated and later found to have a small capacity bladder for her age and underwent an augmentation cystoplasty, and these are her MCU pictures after augmentation. She is now dry and on CIC with a dry interval of about 4 hours. A large number of patients in this country come to you for the first time, having been born with spina bifida, but they land up with the concerned urologist only during adolescence or even in adulthood with severe urinary problems. And this is a large section of our population, and that's why following them up from beginning is important. But we see a lot of them, and this was a girl who came to me about 8-10 months back with an 18-year-old girl with incontinence. She's never been advised further tests or management. She was advised CIC in the beginning, which she did interruptedly, did it for some time, stopped doing it, and was again doing CIC off and on. But of course at this age, if you see these patients, they come with gross upper tract damage, as one can imagine, and with compromised renal function. Let's go to the other group now of patients with spina bifida occulta, which means the external lesion is very insignificant or inconspicuous, but may have serious internal problems. And this is a case with a small bulge at the back, and this boy was, when he came to the physician for something else, the physician noticed this bulge and detected spina bifida occulta. And it is at this stage whether one does a full urinary workup in these. He had no symptoms. So whether we should do a urodynamics in such patients as a baseline urodynamics is a question which comes to my mind. Another girl who came to me when she was about 8 or 9 years old, again a case of spina bifida occulta. The back lesion was just a tuft of hair, but with trophic changes in the toes, and she had trophic ulcers on the toes, and that's what prompted the father, who works in Bombay, to call the girl from Uttar Pradesh to Bombay for a further checkup. And he got this girl who was otherwise okay, but with trophic ulcers, and she had some degree of voiding problems. I mean, she was not grossly wet or incontinent, but at times there were occasional episodes of soiling. And she, of course, underwent investigations, as we have discussed. The MRI showed a bit of dilatation, syrinx here, and a long phylum terminal which was tethered down. And in view of her neurological deficit, it was decided that she would be a candidate for detethering, and she underwent a very simple procedure. If you have a finding like this, is just snipping the phylum terminal. You open the identify the low phylum terminal, low-lying one, and here it's seen very well. And this is something I did jointly with my neurosurgical colleague, and we snip it, and as soon as you have snipped it and you release it from here, it's vanished. So you can imagine how under pressure, under tightness it is, and it's a good operation to do, but one cannot say the same for every intraspinal lesion. Another boy with an intraspinal lesion, insignificant outside lesion, but you can appreciate the very large syrinx inside the cord here, a bit of syringomyelia, also higher up. His skull was okay, there was no hydrocephalus. Many a times syrinx like this will be secondary to hydrocephalus. So if you do just a spinal imaging study would not be enough, you need to rule out hydrocephalus. This boy did not have hydrocephalus. He did not have much urinary symptoms, and he was investigated and is under follow-up. We did put him on anticholinergics. Another girl with a intraspinal cystic lesion, probably a dermoid cyst, and one has to think several times before advising intraspinal surgery for such patients, especially if they don't have significant neurological deficit. And so we have this, a lot of neurosurgeons do consult me as well for intraspinal problems related to spina bifida, and we don't advise intervention early in these patients, neurosurgical intervention. But I'm not still too sure. A lot of people believe that if you have this lesion, which is neurologically, otherwise child is normal, would you do a baseline urodynamic study in order to compare it later with any changes? I mean, that's one question in my mind I'm still not very clear about. Another small intraspinal lesion, a little lipoma at the back, but you have a little tethering, and again a little lipoma, a tongue of a lipoma going and licking the cauda equina. Probably requires no neurosurgical intervention. May require urinary workup for sure. Again, whether baseline or not, we don't know. Another girl who came to me, in fact, not too long ago, an adult, was 21 years old, with spina bifida, with large amount of tuft of hair on the back, and for which she was investigated, found to have diastematomyelia, which is of course one of the most common intraspinal lesions associated with spinal dysraphism, and she is fairly okay as far as her dry interval and continence is concerned. Interesting case where there can be urinary problems when there is spina bifida without any intraspinal significant lesion, but can have definite Arnold-Chiari malformation, and that, as we know, herniation of the brain stem structures downwards into the spinal canal, into the foramen magnum. And this itself, and as I was going through reports and literature, can give rise to urinary problems which need to be identified and treated. Going away from spinal dysraphism, we can have other lesions which give rise to neuropathic bladders by involving the nerves, involving the plexuses, involving the sacrum, or even the higher spine. And this was a girl which we saw 4 years back, tweeted me and said, "This is chronic constipation, I don't know, now everything seems to be normal." And this tumor was not evident from outside at all. I mean, externally there was no swelling. I luckily happened to do a PR, and this was a large tumor. And I immediately told the pediatrician, a senior pediatrician, that please remember what we were taught. I mean, put your finger in, otherwise you'll put your foot into it. But this was this large tumor. As you can see, it's invaded the sacrum, and it was thought to be inoperable. At that point of time, I was given chemotherapy. And she had some degree of incontinence and dribbling. Another boy whom I saw many years back, he's now, I think, 12, and came to me first when I was working at the Wadia Children's Hospital with anorectal malformation. He incidentally had a pouch colon, and he had a sacral agenesis, hypospadia, spinoscrotal transposition, bladder and bowel incontinence. And he was investigated, completely treated, his pull-through was done, his hypospadia is repaired, and he is now fairly continent on anticholinergics and CIC. As I mentioned, this is a condition I have not seen, and maybe some others have. It's supposed to be very rare, called the inverted smile and the occult neuropathic bladder syndrome, also known as the Ochoa or urofacial syndrome. This is the genetic basis of this condition. Pediatric surgeons deal a lot with anorectal malformations and perform the pull-through operations, of which there are some varieties. And as you can see, it's in close relation with the posterior urethra and the lower urinary bladder, and therefore dissection and treatment and operation can cause some degree of damage to the innervation of the lower urinary tract, resulting in a neuropathic kind of bladder and incontinence, and needs evaluation and may require the requisite treatment. Amongst conditions which I have called here the false neurogenic bladder, because there's no obvious neurological deficit or deficiency, is the common condition of PU valves, which has been mentioned by speakers in the morning, so I won't go into any further detail. But these are pictures of a very severe condition, very severe posterior urethral valves, which gave rise to a failed bladder. And this is another boy whom I saw about 8-10 years back with severe PU valves, massive reflux, back pressure, and again he followed up later. This was earlier than when he was fulgurated, and followed up I think about a year or two later. He was better, his one side reflux had gone, but there was still massive reflux on the other side, and the bladder was certainly not good. He eventually, he had the VURD syndrome, that is VUR and dysplasia syndrome, and underwent a heminephrectomy and a uretrocystoplasty. And this is a relatively recent cystogram of the patient showing an augmented bladder with the uretrocystoplasty operation. Fairly dry, but still requires to be on anticholinergics. A small capacity bladder again can function, behave or be present like a neurogenic bladder, and these are some of the causes and some of the findings in such patients. Yeah, I think I will end with that.
We now go to the second lecture. I call upon Professor A. Bagga, whom we all know is a brilliant nephrologist, pediatric nephrologist at that, and he's going to talk to us on 8th stage renal failure and neuropathic bladder. Professor Bagga.
Thank you, sir. It's a privilege to be here, and I'd like to thank the organizers for the opportunity to be here. I must confess two things, that the first confession really is that I work at the All India Institute, which has got a very strong pediatric surgery department. So virtually all our major urological concerns are really handled very ably by my pediatric surgery colleagues. And we really come into the picture for children who have chronic kidney disease. And finally, a very small proportion really would end up having a transplant. So really, of the 50 odd transplants that we have done over the last 8 years, there has not really been any child who's really had a standard meningomyelocele, neurogenic bladder resulting in a kidney transplant, but we have had some patients with posterior urethral valves, some with vesicoureteric reflux, and some with anterior urethral abnormalities who have really ended up getting kidney transplants. So what I'll try to do briefly is to talk about the management of chronic kidney disease in our children, and very briefly giving you an overview of the current state of renal transplantation in patients with neuropathic bladder. The problem with neuropathic bladder, at least in the developing world, which has been again discussed in various publications, including a recent paper from Saudi Arabia, is that children are diagnosed late. Very often they would present to renal, at least to pediatric nephrology services with renal failure. There is an inherent limitation, or people are not very happy doing CICs, and obviously there's a whole gamut of causes, which has all been discussed here today, which could cause a neuropathic bladder. Now, when we are evaluating these patients on the outpatient basis, we do use the Schwartz formula, which we use to estimate the glomerular filtration rate. And this formula you are all aware of, which uses a constant into the patient's height divided by the serum creatinine. And this formula was given almost 2.5–3 decades back, and there are different constants for infants as well as for adolescents. The problem that has happened over the years is that the serum creatinine value has become more and more precise, and therefore the value of K needs to be adjusted for each country, for each region, for each center. And there is a paper that we are presenting at the ISPN this time, in which we are proposing that we should not be using 0.55, but we should be using values like 0.45 or 0.43, because the serum creatinine, the way we do now, is much more accurate than what we used to do before. So the true value of K is perhaps clearly declining in various publications that we are seeing from various countries. This audience is very well aware about the staging of chronic kidney disease, which essentially is based on the estimated GFR that I just spoke about. And as pediatric nephrologists, we would often be managing children who have either CKD2, that is an estimated GFR below 90, or worse. And we are obviously, in the initial part, when we see them, our major emphasis is that one needs to prevent progression of kidney damage in these patients, and only once the GFR falls below 60 or below 30, to be precise, that one really starts managing complications of chronic kidney disease in these children. Once the GFR is below 10 or below 8, the options of renal transplantation obviously are there. Again, this is something that we are obviously concerned with in a very, and I'm sure that Dr. Bajpai is here, there is a lot of interest and a lot of concern on whether we can really slow progression of kidney damage. At least in adults, people would recommend that the protein intake should go down. But we know for children, there are randomized control trials that would say that the recommended protein intake or the recommended normal dietary intake that kids take does not interfere with growth. Therefore, we should not be restricting protein intake in our children normally, even if they have CKD 3, 4, etc. Again, taking the normal protein intake does not increase the progression of renal damage. So particularly in the developing world where the protein intake is so low, I think we are doing a disservice if we are making our kids more and more malnourished by restricting their protein intake further. And as I said, there is enough data that this is safe. And as far as preventing progression of kidney damage is concerned, control of hypertension, and proteinuria is much more important. What about hypertension and chronic kidney disease in relation to neuropathic bladder as well? We know that hypertension is an independent predictor for progression of kidney damage. The standard drugs that we use are either ACE inhibitors or angiotensin receptor blockers. Later on one would add calcium channel blockers, etc. Because this would reduce hypertension. This would also be renoprotective on the long term. Again, there is a lot of evidence-based data on this. Kids where we cannot use ACE inhibitors for various reasons, if they have excessive cough, for example, or if the GFR is below 15 or 12, one could use either calcium channel blockers or use beta blockers. Now, what should be the target of hypertension? Over the last decade, the targets have come down. At least till the last 2 or 3 years, we were saying that we target the 90th centile for age, gender and height centile. But there is this recent study of almost 500 odd patients, the ESCAPE trial from Europe, that very clearly shows that if you have a more intensive reduction of blood pressure targeting the 50th centile, these kids clearly do well on the long term. So our targets for hypertension need to come down by using appropriate agents, ACE inhibitors, with or without adding calcium channel blockers, etc. So this is an important message that I thought we should be discussing today. Kids who, now the other thing that we would, is an important predictor of progression of kidney damage is proteinuria, and it generally suffices that one could just do a dipsticks in the outpatient, and if it is more than 1+, so if it is 1+ or 2+, then you try to quantitate either on a spot sample or which could be on a first or a second morning sample. In most instances, you do not require 24-hour specimens. They are anyway not, they are so cumbersome to take. So spots urine protein creatinine could be used for, in most instances, for monitoring for proteinuria. And if you have patients who have proteinuria, these patients would clearly benefit by using ACE inhibitors, which would reduce the severity of proteinuria if used in the right dose. If you use enalapril at something like 0.3, 0.4 milligram per kg per dose, by almost 40 to 50%. So one would need to take action to control blood pressure, reducing proteinuria, because these would be very major reasons why the kidney disease may progress. And finally, another thing that is often disregarded is dyslipidemia. If you look at, there's not too much data in children, but again we know that for adults, if you have atherosclerosis, there is progressive renal injury. And whatever data that's emerging on chronic kidney disease, even in children, kids do show high lipid levels. So although there is limited data and there is limited intervention below 2 years of age, beyond that age, one does keep doing a lipid profile. And if the children are clearly showing high lipid levels, we generally take a LDL of more than 160 or even 130. One would either intervene by dietary mechanisms, or if in older children by using statins, which is currently the drug of choice. So even in chronic kidney disease, dyslipidemia is a major issue because it again appears to be an independent predictor of progression of kidney damage. Now once patients go into end-stage renal disease, that is a GFR below 15 or below 10, these kids require dialysis. And as far as we are concerned, at least in this country as a group, we would feel that dialysis should really be a bridge to transplantation. Kids could be managed on hemodialysis or peritoneal dialysis for a period of time, but transplantation for children with ESRD, whatever be the cause, is the therapy of choice, because it allows better growth, the psychosocial function improves, and even as far as the cost is concerned, transplantation is cheaper than long-term CAPD or hemodialysis. I'll just slightly kind of shift the gears really and talk to you about some data on transplants, giving you an overview of the current state. If you look at the large Napretics data, 2008, almost 10,000 transplants from the North American Pediatric Transplant Registry. A very high proportion is dysplasia, which could be reflux, obstruction, etc. Obstructive uropathy is again almost a sixth, reflux nephropathy about 5%, and so on. So we've got a major chunk of urological disorders would finally end up getting kidney transplants. And if the younger the patient, the more likelihood that he would be having a structural anomaly compared to an older patient. So if you look at structural anomalies like valves, neuropathic bladder, etc., they are much more commoner in younger children. And if one looks at the graft survival in relation to the primary diagnosis, the best graft survivals are seen in patients who have congenital and structural changes. So, and again, this is not data on from one series or two series, this is data on 10,000 patients. So patients who have congenital or structural anomalies have the best long-term outcomes if one looks at their transplant outcome. A general feeling has been that kids who have had some kind of repairs or who have had surgery to the lower tract have a poorer outcome, and this data is again shown from some data from Tehran. 40 odd patients, a higher rate of febrile UTIs and a higher graft loss compared to normal patients, and a poorer graft survival. So the graft survival was about 92% at 1 year and 45% at 7 years compared to 75% at 7 years for the ones who had not had cystoplasties. So from some series there does appear to be a poorer outcome. Again, there is data from Heidelberg. This data was published in Transplantation about 5 years back. Almost 20% of all transplants, patients had lower tract malformations. And this is the typical distribution that again, you know, we would be seeing in most urological centers: neuropathic bladder, prudent belly, etc., reflux. The graft survival depends a lot on the primary diagnosis. So if you have got a patient who has got a posterior urethral valve compared to, so this is a PUV compared to VUR, the outcomes are better with VUR than with posterior urethral valve if you look at the 15-year outcome. So the graft survivals would very often depend on the underlying etiology. However, so although there is some concern that that there could be concerns with transplanting children with a poor tract, there are enough reports. If one looks at data, again, recent data from Turkey or even from Egypt, about 10% patients having lower tract dysfunction and showing reasonable good follow-ups at 36 months and about 5 years, similar graft and patient survival compared to those with in those patients who had a abnormal tract compared to those with normal kidneys. Again, a similar data from another report saying that almost of 55 odd transplants, almost 40% were in patients with genitourinary disorders, and at mean follow-up of 4 years, 83% patients who had a urological disorder had functioning grafts compared to 80% patients with normal tracts. So it does appear that if managed appropriately, functional urological disorders would not affect long-term transplant outcome. Again, similar data from a series from Maywood, Illinois, 30 odd patients, a spectrum of changes, and showing that although there was a high risk of urinary tract infections, the graft survival at 1 year, 5 years, and 10 years is almost similar to what you would expect in patients who do not have these structural abnormalities. So I would summarize by saying that as far as pediatric nephrologists are concerned, our major concerns, our major aims at the onset are to prevent progression of kidney disease by controlling blood pressure, controlling proteinuria, preventing dyslipidemia and correcting the dyslipidemia. Patients who have structural abnormalities, one would need to correct the structural abnormalities and optimize the bladder prior to transplant. I think that's obviously very important, and I'm sure this is being discussed here on the various modes on which you would optimize the bladder. And if you look at the recent data, it would appear that bladder augmentation, urinary diversion do not affect the long-term graft function, and the long-term graft results are satisfactory if they are done at major centers. Thank you.
Thank you, Professor Bhagav. I now call upon Dr. Mohan Abraham to talk on medical management of a child with neuropathic bladder. Dr. Mohan Abraham We know him as a brilliant pediatric surgeon with a lot of innovative ideas from Cochin. I look forward to hear him.
Thank you, Dr. Sujit, for giving me this opportunity. I'm from the down south, Kerala, that's the southern end of India, and also known as Venice of the East. So if any of you have any visited it yet, I think you should. My endeavor in the next 15 minutes will be to just briefly go through the medical management, which means I'll start with the pathology, the anatomy, as it relates to the medical management, and briefly go over the medical management. I know there are a lot of eminent internationally known pediatric urologists sitting here. Forgive me if I am going to lecture to you something that you already know. Now, bladder innervation is from the pelvic nerve, which is parasympathetic in origin, is coming from S2 to S4, or it comes from the lower down in the spinal cord. And it contracts the detrusor and relaxes the trigon and the sphincter. Now, the sympathetic supply, which originates from T11 to L2. So this is from a higher up area. It passes down, it forms the right and the left hypogastric nerves, and they form the inferior hypogastric plexus. Then these plexus travel to the target organ and contracts the trigon and the sphincter and the urethra. So, as we know, the drugs that we are going to give has to be directed whether we are going to take care of the sympathetic system or the cholinergic system. Now, the problem here is the sympathetic system, the cholinergic system act independently. But most of the drugs that we have, they act on both. You cannot selectively treat one problem without interfering with the other. Now, let's go through the afferent pathways. It monitors the bed volume and the degree of contraction. They are again both myelinated and unmyelinated. And any neuropathic and inflammatory condition, they recruit unmyelinated fibers. This forms new pathways leading to urge incontinence and bladder pain. Now, myelinated fibers gives a sense of wall tension, and they when inflame, they discharge at a lower threshold. So that will explain why in an event of urinary tract infection, the child has a smaller bladder capacity and they tend to void frequently. So any urodynamic study, we have to make sure not only that the urine culture is sterile, but at least there is about a 3 weeks gap between a UTI and the time that you are doing the UDS. Now, the body and the fundus is again, the bladder there are two distinct areas, the body and the fundus, and the bladder base and the proximal urethra. Now, there are cholinergic receptors located that is mainly in the fundus, while the alpha adrenergic receptors are numerous in the bladder base and the proximal urethra. Now, going on to the neuropathic bladder, by definition, is a malfunctioning bladder due to partial or incomplete interruption of its nerve supply. Now, for all practical clinical purposes, this is a classification we all know, that it's either failure to hold urine or failure to empty the urine. Now, failure to hold urine can be due to either an inefficient sphincter mechanism, it's a lax sphincter, a small capacity spastic bladder, as you get an upper motor neuron lesion, a powerful bladder contraction which overcomes the sphincter congestion, like detrusor hyperactivity or overactivity. Now, how do we treat them? We can give cholinergic or sympathomimetic. These relax the detrusor and contracts the sphincter, but do not forget that it increases the residual urine, because you are relaxing the sphincter on one side, relaxing the detrusor on one side, at the same time contracting the sphincter. So this can give rise to upper tract damage. Rosalia concluded that myogenic failure is a result of anticholinergic therapy than a preordained consequence of the valve disease. Now, this may be an overstatement, but there's a lot of truth in it. Now, in the event that you have a high residue at the same time an overactivity, and if you are going to give anticholinergic, you should also think of giving an alpha blocker along with that to lower the voiding pressure. Now, oxybutynin is most commonly used, is 0.2 milligram per kg BD. Tablets are available in India, at least 2.5 and 5 milligram tablets. And tolterodine is another thing that can be used, is 0.05 milligram per kg BD, and they are 2 milligram tablet. The only problem with tolterodine is that the dose that the child requires is so small and the tablet so big that like a 10 kg child will require, you can give you easily oxybutynin 2.5 milligram tablet BD, whereas tolterodine it will be 0.5 milligram, and that will be 1/4 of a 2 milligram tablet. So it's difficult to, the dosing becomes a little difficult there. Side effects are again is anticholinergic, so it will constipate, it will create urinary tract infection because of high residue. There is rise in body temperature, intolerance in hot climate, and body rashes can also occur. Now what we have found is starting at a lower dose. You start instead of 0.2 milligram per kg, you start at 0.1 milligram per kg, and gradually step it up over a period of say 2 to 3 weeks. That will prevent some of the side effects. The child gets to tolerate those heat rashes and the heat generated in the body. Now it's contraindicated in all diseases which has a outlet obstruction, like whether it's a gastric retention or a bladder outflow obstruction or a pyloroduodenal obstruction. Now dicyclomine is again in the books as an anticholinergic, but pediatric surgeons we usually use it for a like an abdominal colic, non-specific abdominal colic. Is an antispasmodic. Dose is about 0.1 to 0.3 milligram. It should not be used with phenothiazine since it can potentiate the action of phenothiazine. Safety in children less than 6 months is not established. It can cause apnea in infants. Adverse effects again, constipation, decreased sweating, blurred vision, mydriasis. Again, it's contraindicated in any patient that has a obstruction either of the GAT or of the urinary tract. Darifenacin is come to the market more recently, but its safety in children is not yet established. Imipramine is something which we used quite a bit in India because of low cost. It's a tricyclic antidepressant. It facilitates urine storage by relaxing the detrusor. It also contracts the detrusor and sphincter muscle, and it also has a local anesthetic effect on the bladder mucosa. So in the event of a UTI, or if there is an underlying, say for example, child is doing CIC, and in the beginning there will be a lot of inflammation of that bladder because of the repeated CIC trauma and also bacterial colonization. Imipramine will tend to sort out that problem a little better than oxybutynin. At the same time, in neurogenic bladders, this is an observation, found that imipramine tend to give more of sphincteric control or more of sphincteric tone compared to relaxation of the detrusor. While oxybutynin acts more on the detrusor, imipramine tend to act more on the sphincter. Now, it should not be used along with sparfloxacin, carbamazepine, tramadol, which we tend to give children for pain, cimetidine, QT prolonging agents like catifloxacin, because it tend to prolong the QT interval and can produce conduction disorders of the heart. Now, because of the side effects and adverse effects, anticholinergic should not be used unless its need is documented by a urodynamic study. If you get detrusor overactivity, definitely oxybutynin is indicated. But blindly giving oxybutynin, I am personally not in favor of that. Now, botulinum toxin, Botox, is coming to market. Is a potent neurotoxin. It blocks the neuronal acetylcholine secretion by binding to presynaptic nerve endings. This has been shown to relax the detrusor nicely, and there are some studies which show that refractory non-neurogenic detrusor overactivity who were injected intravesically with 100 units of botulinum toxin, all children are encouraging results. Now the limitation is, one thing is include general anesthesia. So the effect lasts for about 6 to 9 months, and so every 6 to 9 months you have to spend about 16,000 rupees because one ampule, I mean there's the smallest vial, one is 100 units. We'll have to spend 16,000 rupees every, which I don't know how many poor patients, especially in India, will be able to afford that. Now coming to failure to empty, we usually find in myelomeningocele, especially with a lower down. Iatrogenic causes can rectal or extravesical bladder neck surgery, bladder neck hypertrophy as it occurs in posturethral valve. Now alpha-1 adrenergic receptor blocker therapy is known to produce relaxation of the bladder base and the proximal urethra. Now in BPH, from the adult urology, learning from them, BPH when is treated with alpha-adrenal receptor blocker has been shown to lessen the overactivity of the bladder. Now, this is because even in the presence of an outlet obstruction, the adrenergic receptors, the density of that increases even in the detrusor. And that is responsible for the overactivity. So you block the alpha adrenergic receptor, you also reduce the overactivity. We have been using terazocine. Its tablets are available as 1, 2, and 5 milligram. Dose is 0.02 milligram per kg as an initial test dose. Because some of these children, when you give the initial test dose, there is a transient event of hypotension. We had only one case so far, but it can occur. So the child is kept in the OPD for about 2 to 3 hours after medication, under observation. And if a hypotension occurs, you may have to give IV fluids. Apart from that, there's nothing else that happens. And once the first dose is given and tolerated well, then from the next night onwards, we can adjust the dose anywhere from 0.04 to 0.4 milligram per kg OD. I've been aiming at the lowest dose possible because we don't have long-term studies of giving alpha blocker. And we don't know, because the God-given high voiding pressure in a neonate of 100 centimeters is probably helping the bladder to grow. Now, if we are going to circumvent that by giving an alpha blocker, reduce the voiding pressure, will it affect the bladder growth? This is a question that has been haunting me. I don't have an answer. But anyway, I aim at the lowest possible dose to ensure the PVR is normal and the stream is good. Side effects are dizziness, general weakness, headache, tachyarrhythmias, extremely rarely, and occasional vomiting. Doctorsramesh again is good enough, but again 0.0 to 1 milligram tablet, 2 milligram and 4 milligram tablets are available. Side effects are similar. Now we have, this is in post-urethral valve, not in pure neurogenic bladder. We have tried it in 42 children from January, or post-urethral valve from January 2002 to 2007, and we had an 85% reduction in the PVR with alpha blocker, terazocine. This has been published in Pediatric Surgery International. Now, tamsulosin hydrochloride is an alpha-1A blocker, and it is more useful in BPH because it relaxes the posterior capsule. Now, drugs that contract the detrusor, bethanacol, I don't know how popular it is, how many have been using it. 25 milligram tablets are available, 0.7 to 0.8 milligram per kg, TDS is a dose. It has got a lot of side effects: blood vision, diarrhea, dyspnea, eructation, increased urinary frequency, wheezing, etc., etc. All that can be stimulated by acetylcholine. And also it produces a lot of tolerance, because you start giving it and in another 1 or 2 weeks the child gets tolerant to it. So it should not be given in patients with bladder outflow obstruction, bladder surgery, bradycardia, epilepsy, or any obstructive feature either of GAT or urinary tract. Now this I am just mentioning because it's mentioned in the books. Neostigmine and pyridostigmine, both are more useful in myasthenia gravis. It's a very short duration of action, and dose is 1.8 to 2.2 milligram. And again, it should not be used in any obstruction of the GAT or the urinary tract. To conclude, neuropathic bladder is a failure to empty or failure to store. If it is failure to empty, make sure there is no distal obstruction. If there is no distal obstruction, start on with alpha blocker, or you can try cholinergic. I don't have much of experience with it. Try cholinergic if alpha blocker doesn't work. If it's failure to store, then anticholinergic. Of course, remember that you watch for the PVR every time you are stepping up the anticholinergic. And you can try Botox. Again, watch for PVR even then. Thank you.
Now, I call upon Professor D.K. Gupta to talk to us on when surgery is necessary and options available. I don't think I need to introduce Professor Gupta here. We all know him. Each time I meet him, there is already one more award he has won. So I lost completely track of things that he has. Only thing I'm still waiting, he might one day become President of India. Anyway, Dr. Gupta.
Friends, ladies and gentlemen, it is indeed a pleasure to share this morning this platform with the august gathering in the field. I don't claim I am a pediatric urologist, but being in the All India Institute of Medical Sciences at the tertiary care level center, our 40% work is pediatric urology. Despite that, we are 5 faculty in the department, and Minu is one of them. Not even 5 people can take care of the workload. The sheer volume and our compulsion that we have to deal with makes us think that yes, we have the large volume to handle the children in various fields of pediatric urology. Let it be postoperative, let it be neurogenic bladder, let it be extrophy bladder, hypospadias, and you have to be very selective even to take care of the workload. Coming back to the subject of neurogenic bladder, what are the indications for surgery in this group? As has been pointed out, that the basic management of neurogenic bladder is medical. However, surgeon's choice, center's choice, and parents' choice differ from place to place. And what I would be talking in this lecture would be our own policy at our institution. So when we talk about managing these children, we have ensured that the child has been investigated. We have reached at a decision that what is now the problem that the child is having, whether it is a problem of storage or the emptying, what is the quality of life of the child, what is the job of the parents, and what do they expect from the doctors about that. The next plan would differ if the parents are in job, if both parents are working. Can they take care of the medical management, what we normally prescribe, and that is usually written in the books from the West? And then, of course, what is the status of the bladder, bladder neck, the reflux, the infection, and of course the bladder function itself, and including the upper tracts. So these are some of the issues that one would like to deal with, have the information after detailed investigations. Well, sometimes we have seen even the children that who have a neurogenic bladder and you have a spina bifida. At the same time, this child had an ectopic ureter. And these are only 3 cases in past 30 years or so that I have encountered. Very difficult proposition, and because there was a neurogenic bladder and there was an ectopic ureter, and such associations usually we don't find to mention. So not that we are just trying to manage the neurogenic bladder, and do think that do they have an associated problem. And of course we are not going to miss the real spina bifida cases and the other obvious malformations resulting into this kind of problem. All right, so when we talk of intervention by surgery, it means the child has adequately been given the benefit of medical management. What is that time duration? Cannot be specified in terms of months and years. There would be so many factors that have to be considered, and in relation to the level of education of the parents, their job profile, their level of socio-economic status, and from how far off they are coming to the institution. We have patients like who might be coming just from 200-300 kilometers, but if they have to reach to the hospital after 2 days because they have to come down from high up in the hills, then one has to consider that what could be the best quality of life because of neurogenic bladder in such a child. And I remember Dr. Durayarajan is here when he visited our department about 15 years back as an MCH examiner, and we presented a case of extrophy bladder to him, and I quote it now. Everybody was talking for primary reconstruction and thinking and 5 surgeries and other things, and then I told him this patient comes from Almoda, and then to reach to a bus station he has to walk down 12 hours. And then Pat came the reply and the answer from a seasoned person like him that do a ureterosigmoidostomy. And I think this was a very big sport. And we don't mind resorting even to these unusual decisions, but it is the quality of life that would be better in such a situation. Rather than just doing repeated surgeries, giving him incontinence, giving him leaking urine all the time, smelly, cannot go to school, and his life is miserable. Not only his, but his parents as well. So this is just one example I give you. So that is what the medical management has been tried and it is failed, and now the parents also want that something should be done so that the quality is better, that we have the deterioration in the renal functions, and we have a complicated neurogenic bladder in the form that urinary tract infection is set in the bladder, is small, hypertrophied, thick walled, and this is what we have got. What should be the popular approach? Again, in the background, we will consider all this, that the approach, whatever you adopt, it should be surgeon friendly, patient friendly, it should be simple, it should be convenient, it should be available, and there should be minimal or no side adverse effects. And there should be, you have an approach that you don't lose anything, that you come back and you can always do a next procedure. That is what it should be. And always other options should be kept in mind. So our goal remains to preserve the renal functions, prevent complications, optimize the bladder function, achievement of social continence as much as possible, and facilitation for a self-care, strict follow-up that allows it to happen. Well, surgical options are many. Diversion, bladder neck surgery, depending if the bladder neck is loose. Augmentation, if it is required, I mean, if the bladder is small and tight, one would require that. Ureteric reimplantation, if there is a reflux and persisting reflux with urinary tract infection, and a catheterizal stoma, especially in a girl. And sometimes nephrectomy even, because one kidney may be non-functioning and other kidney is there, and it is the seat of problem, so better to take it out. Needless to say, it does not mean that if there is an underlying pathology associated problem, that has to be tackled on its own merits. So these are some of the approaches. Factors, when we think that yes, augmentation is needed, then question comes, what type of the valve that we use? If the ureter is available, certainly one would like to prefer, but we have used only thrice because it is just not available for this kind of patients. If the reimplantation of the ureter is needed, and if the narrowing of the bladder is needed, and if a stoma would be required. So all these things have to be thought of when such a patient has been presented to you. You have to sit with the parents and also with the patient. They must accept the procedure. Not that because you can do it, you should do it. It must be patient friendly, acceptable to the parents. They must know what are the likely long-term outcome after this procedure. I know because somebody has been taught to use a CIC, perform a stoma, and then give it to the parents, and they say, who will do it? I cannot do it. Both of us are working. For the sake of child, we cannot leave our jobs. So don't force the parents what you want to do or you can do it. Well, choice of segments are many. I personally prefer sigmoid, but Dr. Bajpai has been using stomach. Well, none of them is good. Each one of them has its own plus points, minus points. This is not the platform to go into details, but yes, long-term complications are many, and each one of them has specific to the type of the segment used. Well, that is the reason we have to think of an alternative. Can we reduce the complication at the same time augment the bladder? Yes, ureterocystoplasty is certainly better with less complications. But unfortunately, in this kind of condition, very few chances will be there that you are provided with a non-functioning kidney, dilated ureter, and you use the ureter for a ureterocystoplasty. Well, there could be auto-augmentation, and there has been an experience in the past, but now people have learned that when you denude the detrusor and allow the mucosa to bulge, yes, capacity increases, but slowly it comes back to its normal phase. So it is not a good option. Then, could it be that demucosized intestinal flap can be put onto that, remove the mucosa and put the intestinal flap? Yes, this has also been tried, but again, not many people are doing it, so no long-term results are available with this procedure. Bladder regeneration or substitute, that is something that is being talked about, and some work is going on from a couple of people tissue engineering, though Atala and Amulya, they are working in this field, and maybe that after 10 years we will have some more progress. Same is also about the stem cell. Can it work out in neurogenic bladder? We have limited experience, but a long way to go. However, many people, researchers, academicians are thinking that can we improve the bladder function? That is our aim with the use of stem cells. We can modify the stem cells, can direct them into the desired cells, which will remove the need for any medication, which will improve the function and contractibility, and this is what is needed. And so in this connection only that we are going to have the scientific deliberations day after tomorrow at our institution with the national international faculty, and let us learn that what's going on around the world and what do we expect after 10 years or so. Well, I may also mention that there is one ZIA procedure, and this is the person from China. You might have heard about him, and he is anastomosing the nerves in patients with neurogenic bladder, and in his own hands he claims that 80% of these patients improve in their function and contractibility. And if it is so, it is a remarkable progress in this field. Remarkable. Well, others have also used it, and they claim about 60%. Even if there is a 50% success with this kind of procedure, I think we are heading for a major breakthrough in the surgical approach of a neurogenic bladder. I personally do not have any experience. I cannot comment on it, but I have a patient from US who came to us, and now he is going for the GIA procedure very shortly. I think that was the last slide. Okay, I think I would like to stop Mitra here, and we would be happy to discuss anything subsequently. Right. Thank you very much.
Thank you very much.